So if anybody needs to go take a nap, now would be your time to do it. If having a hard time staying awake, I was. So once again, images, not because of Lenny's lecture. I just ate. That's why. And it was pasta. I was carb loading. Images from Visible Body app. That's where I got a lot of images from. So overview, once again, we'll kind of blow through some of these redundant slides in the sake of time. But once again, the 5 Ps. Case study, Holly, 76-year-old female, complains of lateral elbow pain made worse by golf. I know that's not golfer's elbow, but this is where her pain was. She had a PRP injection about 6 months ago, which didn't help, followed by a steroid injection, which did help for about 3 weeks. These were not by me, but she came to see me saddened that she may have to give up golf. A retiree that's now looking at giving up the thing she loves. So I went to a leadership training recently. And just so you know, I never asked to be a leader, but I figure if I keep going to trainings, I could ask someone if I could be a leader. So I went to this leadership training. I saw David Rabigo use this today, actually, this Venn diagram. And it turns out you can explain just about everything with this. And in our case, is Michael Yelland here today? Did he leave? He's here. So in the green circle, we have Scarpone, Prolotherapy rocks for lateral epicondylosis. We have the Yelland in the red, Prolotherapy rocks, but no better than physiotherapy for lateral epicondylosis. And then in the yellow, we have variables. But it turns out if you inject in this spot, called the sweet spot, everything works really well. And this is what I learned in my leadership conference, that if you use a Venn diagram, you sound really smart and your variables don't matter. So we'll move on from there. Did that help with the leadership? Did that help you? David used one this morning. Preparation, once again, same thing we've learned in the past. Position, we need correct position for patient compliance during the injections, as well as physician ergonomics. For the lateral elbow injection, you can do this lots of ways. Your job is to get at the lateral elbow. You can do it seated, you can do it supine, you can do it prone. I prefer the supine position secondary to avoidance of syncopal episodes. So even people, and also motion. So if people have a tendency to move and jump out of the way, we're kind of dealing with some small structures right now, so we don't want to have to chase them around with the needle in order to inject them. So I find that the supine position works really well. Make them comfortable, elevate their head. You can put a bolster under their knees if you want, and then put the elbow in a position where you can get to it. For the medial elbow and the posterior elbow, it's a little bit trickier. Well, it's not that much trickier. Just abduct the arm up over the head, palm up, basically facing the ceiling. The same position you do for a breast exam or something like that. So the arm's up over the head, and you get the medial elbow and the posterior elbow this way. So that works for me. You can sometimes bolster it if you'd like for comfort, but generally works pretty well. Physician position, sit on the stool next to the patient. The elbow secured, you're secured. I have stuck myself when people jump. So if you stick something and you're using a small needle, small space, you're close to it, and they bounce around, then you gotta have, if you keep them secure, then that's not gonna happen. Points. So we're gonna talk about points, not too quickly, but the elbow, we're doing elbow, wrist, and hand. These are small areas, and so you can cover a lot with few injections. For the lateral elbow, one of the important points is going to be the interarticular injection. And this is a really easy way to do it without guidance. You can all feel on your own elbow. Just palpate the area between the head of the radius and the capitellum and go a little bit posterior to that, and you'll feel a soft spot right there. That's the entrance to the elbow joint. So you can easily palpate that, easily inject it. This is not a large joint like the ankle or the knee or the hip. It doesn't hold a lot of volume, so 2 to 3 cc's, a 25% dextrose in there would be sufficient. The other points on the lateral elbow are also easily palpable. So if the most prominent structure is the lateral epicondyle, and we refer to that as the lateral flat surface. There's multiple things that attach here, include ligaments and tendons. So it would be lovely if we could dissect down and say, this is where this comes from exactly. It doesn't happen that way, but they all blend in together, and this is generally a very palpable spot, very easy to find, very tender on lateral epicondylosis or itis. But that's referred to the lateral flat surface, and that lives there is the ECRB, the common extensor tendon, and the supinator. So all three of those right there in that area. And a little bit superior to that is the anterior flat surface, which is the origins of the ECRL, just right there. And so this whole area is less than 1.5 centimeters. So it's not like these are stretched out. And the picture looks like you have a lot of space there. You really don't. And if you feel the skin on your lateral elbow, you can actually move it probably 1 centimeter back and forth. So maybe one injection site with some skin sliding would be sufficient to hit this area. And then, yeah, that's kind of where we're at. So as far as anatomy goes, if I were to draw this, this is what it would look like. So this yellow would represent the radial nerve as it runs anterior. If you're in the anatomic position, the radial nerve is going to be anterior to the radial head. That's where we look for it. And so in order to avoid the radial nerve, which you would want to do, you would push it back with your thumb, with a digit, some finger, reach around, pull it back, so then you can inject the radial head safely. And I just indicated a couple injection spots on the radial head where the radial nerve would be if I pushed it back, and then the lateral epicondyle with the intra-articular injection site there. Okay. And this is for demonstration purposes. This is an ultrasound image of Holly's elbow. And I try to line up the anatomical structures like the bony interfaces don't necessarily line up, but what we're looking at here is radial head and then lateral epicondyle. Radial head, lateral epicondyle in those areas. You'll see on the skeleton model, tendons attach here and ligaments attach here. On the ultrasound image on the right, you'll see a small interface right there, if I can keep my pointer on it. I don't know if anybody can see that if you're close enough. But anyway, that would be the distinction line between the tendons and the ligament. So the radiocollateral ligament would be below that fine black line, and then the tendon would be above it. In this case, we see tendinopathy, so thickening of the tendon at its proximal interface. But the point of this slide is the fact that about halfway up this slope, this ski slope, we talked about cornices last time, we'll talk about ski slopes right now. Halfway up this slope is this interface between tendon and ligament. And in fact, about 30% of all tendinoses have a ligamentous component with it. So with your palpatory skills and your ability to do prolotherapy, it doesn't seem like it would be a problem to hit all of this interface with a few injections. But that's important to think about as far as destabilization of the elbow or even chronic elbow pain. So the Varus stress test for radiocollateral or LTL instability. In order to stress the ligaments of the elbow, you can't have it in extension because the olecranon would be then locked into the olecranon fossa. And so we have to have some degree of flexion, 20 to 30 degrees of flexion, and then institute a stress across the elbow. The elbow is not as easy, or at least not as, I guess easy is the word, perceivable to feel stress in the elbow. The reason being is it's attached to the shoulder, and every time you stress the elbow, the shoulder opens up or moves. So to have a perception of feel in the elbow is very, very difficult. So the better chance you'll have is if you can stabilize the shoulder a little bit and then introduce a stress. Sometimes the stresses are so small, a 2 to 3 degree opening or a 2 millimeter opening of that joint is sometimes not perceptible to look at. Like when you're testing an LCL or an MCL on a knee, you can see that thing just swing open like a hinge. Whoa, that's torn. On the elbow, it doesn't really swing open like that. So maybe end feel is a good indicator of ligamentous instability or even pain with the maneuver. But I haven't had as much luck as I had with knees because the elbow flops around. If you can secure the shoulder a little better, you'll have a better chance of making that work. So anatomy, above the anterior flat surface lies the brachial radialis origins. Just proximal on up, but not too far from that same area, right along that same line. And then a little further down, we have extensor carpi radialis longus, which is coming from the anterior flat surface, And in conjunction with, we have the radiocollateral ligament and the annular ligament of the radial head. So you see these fibers start to blend together, and that's why I showed you the ultrasound image to see, like, they really do blend together. They're not that far apart. In fact, they share very common planes. But nonetheless, that would be the anterior flat surface. And we go down a little bit further, and I couldn't make the ligament go away to show you the insertion of the extensor carpi radialis brevis onto the lateral flat surface. But that was the point of this image. And if we remove the ligaments, then we can see the supinator that attaches also on the lateral flat surface. So you're going to hit a lot of tendons in this very small area. And as far as, if you think how big your finger is and you push on it and you create pain, that pain, we know it's somewhere in the lateral epicondyle, but not super sensitive or specific. Well, it's sensitive that they have pain, but you don't know which one of these tendons is involved. We just know the most common ones that are involved. But nonetheless, they would get treated if you put a needle in that area. One more piece of anatomy, the anconeus. It's a strange muscle, but it's in kind of adjacent to this lateral epicondyle, and sometimes can have pain. And I learned a great deal from a marimba player. Does anybody know what marimba players are? You guys know? I guess I'm the only uncultured individual in the room, but yeah, it's like a xylophone, but it's bigger. I don't know why they call it marimba, but anyway, marimba players, I learned this from having a performing arts kind of practice, have this pain a lot, the anconeus pain. So that was very interesting because they hold two sticks, and they do a lot of movement with their wrists, and it's kind of interesting. But that's where the anconeus lives. So the radial nerve, once again, this is just a description of radial nerve. How you hold it out of the way, super easy to do. The reason you hold it out of the way is because you're not going to inject your thumb, so you're going to avoid your thumb, which means you're going to avoid the radial nerve, and you're going to hit the radial head or the annular ligament. So this is just a description. Radial nerve coming down here, you move it up out of the way, and you should be good. If you do hit the radial nerve, that can cause wrist drop, so you're trying to avoid the radial nerve. Procedure. This is for lateral epicondyle at this point. You palpate and mark the soft area. This is for the intra-articular injection. You use 2 to 3 cc's of 25% dextrose. And that's a pretty rewarding injection to do. It actually works very well and pretty darn easy to do. Lateral epicondyle and annular ligament. So same thing, hold the radial nerve out of the way. And in this position, depending on the pain, you can actually supinate, pronate the wrist, which may bring the portion of the annular ligament into your view without more needle sticks. So that's a possibility. And you can also slide across the radial head pretty easily to cover the extent of the radial head. And then lateral epicondyle in this position. Generally, I wouldn't need more than 4 to 6 injection sites to cover an entire elbow. I think you could do it in 4 with skin sliding. Lateral elbow injections, this is just showing, there's a couple ways to do this. You can go directly into the lateral epicondyle, or you can come distal a little bit and come more into the tendon junction. Remember that ski slope area? We're trying to cover it all using a peppering technique. And this is once again that ultrasound picture showing radial head. This is the joint, and then up onto the lateral epicondyle. So in theory, one way that you could do this was our insertion point through the skin. We could stick a needle in. So you're looking at a 27 gauge 1.5 or 25 2-inch needle into this area, and you can basically walk it down the slope. It'd be easier, however, to start here and then walk it up the slope so you kind of know where you're at. Fanning it out and using a peppering technique and injecting on bone, obviously. You can read direct down, hit the annular ligament on the radial head, or the other option is to come straight down on the lateral epicondyle, skin slide straight down, skin slide straight down. You have to use more sticks or more entry sites to do it that way, but that's also very, very acceptable. So now this is just reiteration of what I just talked about. So just points, injection points into the lateral elbow. So medial elbow, we have once again a very small space with lots of tendon attachments. So the common flexor tendons where they attach. We have the flexor carpi radialis longus up here, the pronator teres right here, the flexor carpi ulnaris right next to it, flexor digitorum superficialis here, and palmaris longus tendon as inserts right there. So a very compact area. In the medial epicondyle, you could even use less injection spots because the skin is even more mobile in that area than it is on the lateral side, and you can slide it around to hit that medial epicondyle. If we're concerned about the ligament, however, we're going to have to go a little bit distal in order to hit the ulnar surface of the ulnar collateral ligament, so the ulnar side of it. Going from there. As far as testing UCL instability, this is called the milking maneuver or milk test. You can do it yourself. So you put your hand up, reach across your body, and then externally rotate. The intent there is to open up the UCL ligament. So a positive test would be pain or gapping of the joint. And once again, there's so much motion through the shoulder into that position, it's always hard to see that gap occur, to see it visibly with your eyes or even to feel it. But pain is always there with that gapping motion.
Are these slides not on the thumb drive?
Yeah, it was late last night. There's for the most part they are, and then there's a few pictures I added last night. Actually, this one I did add. So I wasn't going to do testing, but I thought that might be something important. So the milking maneuver is what opens up that UCL ligament. So this is the ligament that gets injured in our pitchers, our young throwers that can be injured. And there's really not, for a partial tear of these ligaments, there's not a great treatment option other than a prolotherapy type injection. For a total tear, then surgical would be your standard of care. So once again, we have flexor carpi radialis longus insertion, flexor digitorum superficialis insertion, or origins, excuse me. Pronator teres, flexor carpi ulnaris. Just I'm kind of blowing through these because they're all right there in the same spot. We're going to inject them as we go. And the thing to avoid on the medial elbow is the ulnar nerve. So that's what we're really concerned about. Fortunately for us, the ulnar nerve lives right here in this groove, and it's easily avoided. The only thing you have to worry about is they have a sublux ulnar nerve, but if you palpate there, you should be able to feel the nerve as it pops in and out, or it's not going to be a problem. So to inject, if I put my thumb right here over the ulnar nerve, I can come safely in from the medial side and pepper that area without too much difficulty. And the ligamentous structure, you have the anterior, the posterior, and the transverse portion of the UCL ligament. These will be, if you are doing prolotherapy of the medial elbow, these will be treated at the same time. You can be more specific if you slip posterior and you palpate in this area, maybe it's a transverse ligamentous injury. You could prolo that area. If it's more posterior than it is anterior, you're going to have anterior. Without imaging, it's hard to decipher. Like I say, your finger is pretty wide. When you palpate, it's hard to get that precise when palpating here, especially if there's a partial tear or some sort of ligamatosis going on. Once again, the course of the ulnar nerve as it passes posterior to the medial epicondyle through there. And posterior elbow injections are wonderful. I wish more people had triceps tendinosis. I don't get to see triceps tendinosis very much. It'd be awesome because it'd be so easy to hit. But nonetheless, right on the olecranon is where you're going to pepper. And you guys should pepper. There's kind of a medial band and lateral band. You can kind of pepper right across the olecranon very safely and do that. If you have any trouble with the joint injection I showed you earlier, this could also be work for a joint injection. If you go through the triceps tendon down into the olecranon fossa, you're in the joint of that space. At that point, you could inject there as well. But that would be super awesome to have lots of that problem. I very rarely get that problem. So procedure for lateral elbow, consider 27 gauge, inch to inch and a half needle. You could probably get away with a half inch, but you wouldn't be able to redirect very well. You pepper the areas of pain, the insertional areas, and remember that the radiocollateral ligament occupies the lower 50% of that slope that we showed you on that image. Careful not to hit the radial nerve. Don't get too aggressive and actually hit the radial nerve. I haven't had the opportunity to hit the radial nerve yet, but I have heard stories where someone had a wrist drop for 6 weeks, secondary to an injection in or through or around the radial nerve. So be careful because it's easily avoided. Medial elbow, same story, 25 gauge or 27 gauge needle. Use a peppering technique to hit those areas. Lenny said, the foot is easy, the elbow is also not terribly difficult, just be secondary to the very superficial structures. They're very, very superficial, and you don't have a hard time getting to them. And this is once again my position for a medial epicondyle. This would be the humerus portion. This is the ulnar portion, and then the ulnar nerve as it goes through the cubital tunnel there. And my thumb would be guarding, so I'm not going to stick my thumb. Posterior elbow, same gauge, same story. Avoid medial angulation towards the ulnar nerve, and you should be okay. This can be done in a sitting position where you cock the elbow back up into this position, and then you can pepper the emphysis with that maneuver. Triceps tendon, that's it right there. So that's a maneuver. Problems: radial nerve injury, ulnar nerve injury. Try placing a finger where you don't want to be. That way you're going to avoid it for sure. You won't have any reason to hit it. And that is kind of the elbow portion of that lecture. Is there any questions on the elbow before we go on to hand and wrist?
What do you do for olecranon bursitis or effusion?
So you're asking me personally what I do for olecranon bursitis or effusion. So prolotherapy is, I've read one, I wouldn't call it article, journal article. I've read somebody's experience with those things where they inject a 25% solution into the bursa. I haven't done that personally. Depends on if it's an acute bursa versus a chronic bursa. If it's acute, I don't do anything with it. I give it time, let it get better. If it's chronic, you can drain it occasionally. But I haven't personally had success putting 25% extra into the bursa. Has anybody had success doing that? Okay, so sorry. Those are tough ones. Any other on that? Yeah.
After an elbow dislocation, 3 weeks later, and they're still having limited range of motion, can you start prolotherapy?
Right. So the question is, after an elbow dislocation, can you start prolotherapy? And you can, but to my knowledge, all the elbow dislocations I saw have interrupted multiple ligaments in the process. So that requires a surgical fixation in most cases. In the cases that I've seen, I would say after that, and they're still having pain, yes. But their propensity to re-dislocate after an elbow dislocation is really high, with very minimal forces.
One tidbit on the olecranon bursa. I had a patient I drained very early on who ended up with a chronic draining elbow and had to have surgery because the olecranon bursa is so close to the skin. Every other bursa, you have an inch of fat to seal off the hole that you made, but it's literally under the skin. So he drained for a month and a half synovial fluid and then ended up having surgery. So I don't ever put a needle in unless they've had symptoms at least a month.
Right. Yeah, bursas are just no fun to work with. I mean, well, the true bursal effusions, like on a prepatellar bursa or olecranon bursa, they're just difficult, especially like hockey players, and people land on their knees a lot. They're tricky. Hand and wrist, similar story. This is the injection that I will do sitting up oftentimes. So the hand and wrist injections, I will have the patient sit up, and I actually have them sit across the table, the exam table from me, and I'll sit on the opposite side, and I'll bolster their wrist or whatever direction we need to be to open up the joint that we're trying to get at. In this case, this is an example of a TFCC or a ulnar collateral ligament injection, but seated opposite so you can get comfortable, get the needle where you want it. And I generally wouldn't use that needle, it's just for picture purposes. So the points of the wrist, this is kind of neat because the anatomy kind of works out here as you start palpating and whatnot. But the joints we're concerned about for our purposes today are the scapholunate joints. So everybody can palpate the wrist and they're going to have a bump right on the radius. So almost in the middle of the wrist, you're going to have a bump there. And that's called Lister's tubercle. So that tubercle separates compartment 2 and 3 of the dorsal compartments. And if you fall off of Lister's tubercle into the wrist joint itself, and then continue along until you hit a bony structure, and then, well, it's going to be towards the middle finger, basically. That's going to be the area of the scapholunate joint or the scapholunate ligaments, right there in that area. That's where we're going to look for scapholunate dissociation or pain with a fall. And they always talk about these swoosh, fallen and outstretched hands. Like, has anybody fallen and not fallen on an outstretched hand? I mean, like fallen like that? I mean, I think it's rare. I think everybody falls on an outstretched hand. I mean, like, if you don't stretch your hands out, you're in your head. So anyway, that's why everything happens with a fallen and outstretched hand. But that can happen, and you can lose grip strength or something like that. So that's the scapholunate joint. So it's just distal to Lister's tubercle, right in the center. If you draw a line from Lister's tubercle to the middle finger, you're going to be right in the region of the scapholunate joint. The distal radial ulnar joint, right here, you can palpate that as well. That's the fun thing about the wrist and hand. So you basically fall off the ulna towards the radius, and you're going to be in that joint. The finger joints, we'll kind of go over those here in a second, and the thumb joints. The ligaments, we're going to talk about the radial collateral ligaments, the ulnar collateral ligaments, and the triangle fiber cartilage complex as all possibilities to inject for wrist and hand pain. And a lot of my patients, it's not necessarily falls, but just wear and tear and age that creates this destabilization of the hand, which is very well treated with prolotherapy. So here's just a anatomical rendition of the same thing we just saw a second ago. So if we come off Lister's tubercle, which we're supposed to be here, draw a line to the middle finger, we're actually going to end up in the scapholunate joint. If I take that ligament off, sure enough, there's a scapholunate joint right there. I think that's what I'm pointing. No, it's that green dot right there. So that's pretty consistent. I rotated that picture just a little bit as far as angulation. That's why it looks a little bit different, but nonetheless, that's that same point. The distal radial ulnar joint is going to be in this region right here. The radiocollateral ligaments or radiocarpal ligaments are right here, and the ulnar collateral ligaments with TFCC is going to be in this area. CMC joint will be here. We have the proximal carpal roll and the distal carpal roll. There's a whole bunch of ligaments in there. I don't know the names. I bet they're associated with the bones they attach to, but if there's pain in that area, that is a pretty safe place to inject. This is a TFCC. The TFCC is a tricky complex. It's a fiber cartilage complex like a meniscus that resides on the ulnar side, deep to the ulnar ligaments. And this is the palmar surface. This would be the palmar surface of the hand. This would be the dorsal surface of the hand. And there's the TFC residing deep in there. I haven't seen a lot of studies that say prolotherapy is great for TFCC injuries. I've treated a few myself, and my outcomes are really mixed. And so I would say, if I think that, I'm a pretty positive guy, my outcomes are great, I would think, well, maybe something else is going on at that point, or my TFCC is not responding to my prolotherapy or something like that. But nonetheless, the ligaments above it that do stabilize it or superficial to it may be a very good target to hit as well. I'm not discouraging you from hitting the TFCC, I'm just telling you my experience with hitting the TFCC. And then some structures maybe possibly to avoid. Dorsally, you have this superficial branch of the radial nerve that kind of crosses in this area, the same place where intersection syndrome occurs. Not really going to hit it that often, and when you do, and you're down in the wrist, it would be these little things here. And I've had my wrist injected, and the practitioner did hit one of these, and I had a buzzing in my first finger for about a week and a half, and then it went away. So I'm not telling you it's okay to hit the nerve. I'm just telling you sometimes it happens, and you can't palpate them down at that level, so there is a possibility that you could hit them at a time. So if you go slow and don't put your needle right through them, maybe that's a good thing, but nonetheless, be aware of those things. And then I think that was all I want to show you. The recurrent branch of the radial arteries, you have a palmar branch and a recurrent branch. They are going to be right at the level of the CMC joint, for the first CMC joint. These are palpable, especially so when you're injecting these, think of the people with this kind of pain. It's generally a older, more mature individual with thin skin, and you can palpate the pulse really well. So just avoid it. Don't do an ABG, just palpate the pulse and go around it, work around it, and you'll generally be pretty safe. But you can palpate that pulse pretty readily if you start to look for it and feel for it. The reason I know, I've hit a lot of them, actually. I like, that's interesting. So you put the needle through, and you get a flash of blood into your syringe, like, oh, just hit the artery. Just hold pressure for a couple minutes, and you'll be good. And it's amazing, because when I was a resident, I would try to do ABGs, and I would miss them all day long. And like, how did I miss it when I look for it and hit it when I'm not looking for it? It's like turkey hunting. You never see turkeys when you're turkey hunting, I'm just saying. You see deer when you're turkey hunting. But move forward. My wife told me not to use hunting analogies. That's not a good thing. So this would be the palmar surface, and what we're worried about here is the ulnar nerve, the radial nerve, and the radial arteries. What we're trying to show at that point. So if you're doing a ulnar collateral ligament injection or ulnar carpal ligament injection, don't go too far anteriorly, or a TFCC injection, don't go too far anteriorly, because that is a possibility. But with that nerve, nerve. As soon as you get close to it, they let you know that you're close, and that's nice. So if you go slowly, that should be okay. The next thing is the procedure. You can use a very small needle. So since I'm up here, I'm going to talk about my preferences. I don't like using short needles. I don't know why. I just don't feel like I can work around things. So I don't use really long ones either, but I like at least an inch to an inch and a half needle. I prefer a 27 gauge inch and a half in these areas because I can bend it, I can maneuver, I can do whatever I want with it. But when I get a half-inch needle, I feel like my hands are too close together, and that may be just a feel thing. But I feel like I'm more dangerous with a shorter needle than I am a longer needle just because my hands are close together. So proprioception. So pick a needle you want, and that will work. For injections of small joints in the hand, traction is very helpful if you can't get in, especially for arthritic joints. So joints like we have are pretty easy to get into, but once you have some osteophytes or some exostosis or some sort of bony growth, they're more difficult to get into. And so when you do get into them, they're very rewarding. You feel that donut sign fill up under your fingers. So the TFCC. So there's a couple things here. If you're going to go after TFCC, you should at the same time go after the ligaments that are, so the ulnar carpal ligaments as well. And from one point, you can see how small this area is. TFCC resides right here. Triquetrum resides right here. We can basically redirect into these areas to hit that all at one time. You don't need to do multiple injection sites right there because you can go through pretty quickly. And then once again, so the injection site for the scapholunate joint and the distal radial ulnar joint. Just pop it in. As far as amount of solution to put in that joint, once again, 2 to 3 cc's, 25% dextrose should be sufficient. And that's the scapholunate joint injection. It's pretty straightforward, straight down in the joint, and not all the time. So if you go down a hip bone, inject right there. Don't fish around for the joint. You can pick it up, skin slide, go down and inject, because chances are you just hit the scaphoid portion and the lunate portion, and now you're looking for the joint. Also, the carpal joints communicate with one another, so they actually do hold some fluid, so you wouldn't see that sign that you see with a finger joint, like that big swelling that occurs. But if you go down and hit something, inject. Don't just keep pushing around till you get it. You'll be kind of frustrated at that point.
You try to work around like extensor carporadialis tendon there?
I do not. I'd probably just go right through it. So the question is, as far as extensor carporadialis or even the common extensor tendons, you're going to go through them. In some cases, you'll probably go around them in other cases. But as far as palpating them and moving them, I wouldn't consider it. Any other input on that question? I mean, you're tough to palpate anyway. Finger joint injections. If you put traction on, open up the joint, you can do this. Your nurse can do it. It works very, very well, and you're able to pop it in the joint, and you'll be good. As far as approach, if you can avoid the extensor tendons pretty easily on the fingers, secondary to you know that it's going to be midline. So just go off 45 degrees either side of the joint, the corners of the joint, you may say, and that's a good place to enter. There also seems to be more comfortable in those positions as well, and you can work on up all the joints of the finger in the same manner. This is kind of just a busy slide demonstrating possibilities that exist from similar injection points. So you don't have to put 50 points on a hand to hit 50 points. You could actually put maybe 30 points on to hit 50 points with needle direction changes. But this structure is so superficial, you have this oftentimes happen when you back it out, you pop out of the skin, you have to put it back in and do the same thing. So it's kind of tricky in that manner, and just kind of a drawing in that position. So problems, arterial or venous puncture are very, very common in hand injections. Just be aware that they are. Avoid them if you can. Nerve injuries, and I would say tendon injuries as well if you're going through those, but that has not been a problem in my practice. Overinflation of small joints has been a problem because, like Lenny said, maybe because I have 5 cc's doesn't mean I should put 5 cc's in a finger joint. That's just common sense, but you get excited when you feel it start swelling, like, yes, nailed it. And then like, ow, 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 ow. Then it can ache for a couple days. So overinflation of finger joints would be a common problem and something you could easily avoid by monitoring how much solution you have and using a smaller syringe like was mentioned earlier.
Do you use bleb on the hand like he does on the foot?
I do.
Even a little finger joint?
If I'm using a 27 gauge needle, I usually don't use a bleb. So I tell them, hey, I can stick you twice or I can stick you once and it's going to feel the same either way. The problem I get into though, so if I put my needle in and I miss the joint, which I commonly do the first time in, and you have to redirect, then it becomes uncomfortable. So sometimes it's easier to put the bleb in so you can do some skin sliding and it's not as uncomfortable for the patient. But you can give them a choice, especially if you're blebbing with a 27 gauge or 30 gauge and you're injecting with 27 gauge, it's really not much difference. Good question. Conclusion, in conjunction with prolotherapy and aggressive physical therapy, which included golf lessons, Holly was able to make a gradual return to sport that she loves. So in this case, it wasn't an elbow injection that saved her. It was actually the physical therapy that evaluated her functional motion, her functional movement, and her deficiencies that kept leading to this problem in the first place. This was just an end stage breakdown, or end chain breakdown. So I rolled through that super fast, and I'm on time, so what questions, if any?